could sit around. We are glad that we can sit around our devices. Some might be right in front of their computers. Some might just be right in front of their phones, as the case may be. We are very pleased that the global network for people living with HIV could put an event of this nature that will be beneficial to all of us regardless of geographical location, because the template and the situation upon which we are commemorating today is a global phenomenon. And as such, it doesn't mean that we cannot learn lessons from one another. So today, as you may have seen in the flyer, there are going to be two lead speakers whom I will be interrogating. By the way, you also have the privilege to be able to drop your questions on the chat option. And then, of course, we will look at these questions that you would have made available. In no order of priority, we have today that will be part of the conversation, Mr. Nelson J. Otwoma. Nelson will be of this conversation today, and Nelson serves as the chairperson of the Network Empowerment of People Living with AIDS in Kenya, which is generally referred, that organization has the acronym of NEPHAK, okay? Network Empowerment of People Living with AIDS in Kenya. He will be with us, and we will look at a number of perspectives given his wealth of experience, especially insight on community tuberculosis and the prevalence of its launch. Furthermore, we also have another erudite and indeed a person that you will also be glad will be here. We have Merinda Sebayang. Merinda Sebayang is of the Positive Indonesian Network. So she will also be a speaker today. Just to say a little about Merinda, she is the founder and chairperson of the Jarang Indonesia Positive Indonesia Network, okay? And that network is often, given the acronym JIP. The Positive Indonesia Network is a national network of people living with HIV/AIDS. Added to that, Merinda also serves as the country representative of APSCACOS, and she's also a member of the WHO regional validation team, that is the Pacific region where she is domiciled. Distinguished ladies and gentlemen, I will request that our speakers, if they are here, to turn on their video so that we can put a face to the names therein. We want to really be grateful to Andrew, Cheng, Claire, Constance, Edgar, Ibrahim, Idara, Miriam, Randy, Richard, and Wang. We're glad that you could be here with us. Just to reiterate what I have stated earlier, the webinar of today is being recorded and also is being translated into French and Spanish. So you are at liberty to pick any of these that suits you best if English is a bit difficult. Now that is Merinda. Thank you so much, Merinda. It's good to see you smiling. And I hope you're having a beautiful time in Indonesia.
Yes, well, indeed. Now I'm in the Surabaya city, one of the city in East Java.
Okay.
So it's really nice to be here, and thank you for the opportunity, especially to the GNP Plus to having me here. Over to you, Jonathan.
Thank you. Thank you. Thank you so very much. Distinguished participants, it is no news to us that the universal health coverage, means a lot to every person, regardless of where and what you do. The quality of health services that we often do enjoy has a role to play in making sure that this narrative, and the meaning upon which universal health coverage has becomes clearer. And then, of course, it will be good for you to know that the universal health coverage, UHC, universal health coverage, finds its strength also, among many other things, under the SDGs, SDG number 3, to be more specific, which focuses on health and well-being. And this is indeed a requirement that the United Nations have deemed it fit to say, listen, we must look at health systems in transition from a vertical point of view, and let's see how we can be able to help people of various demography, how they can be able to achieve this quest upon which we are calling out for. And so I have a number of questions that I'm going to engage Merinda just before Nelson will join us. Is Nelson here? Please, if Nelson is here, we'll be glad to also hear your voice.
Yes, I'm here. Yes, I'm here. Sorry, I arrived slightly late, but I'm here.
Ah, beautiful. Welcome, Nelson. It's a pleasure. It's a pleasure to have you here. Merinda, I will start with what your experience have been, especially within the network that you work, the Indonesian network, okay, of individuals who are confronted with HIV and AIDS. What has been the success story or testament that you will say people living with HIV and AIDS in Indonesia have enjoyed as a result of the availability of UHC? Because sometimes it is easy for us to focus more on the problems without even remembering that there are some small gains that have come as a result of that. So what exactly has been the experience? That's we'll pick up from there.
Okay, Jonathan, and am I audible? Can you hear me? Because I think I have a problem as well with my connection, but I hope that my voice is clear.
Yes, your voice is clear. It's clear.
Okay. Okay, so surprisingly, our government already have our national health insurance, and I think more than 95% of the citizens of Indonesia already have the national health insurance. It's our national health insurance is the proof that the government have a commitment for the UHC. However, it will speak differently if we talk about access to health services, especially for the people living with HIV and also the key population. Although that right now, especially at the primary health care, the government provides services as subsidized, or we can call it free, but there are some hinders or barriers, especially for our communities, people living with HIV, also key population, to accessing health services. So, for example, that maybe for some of the essential medicines is already covered by our national health insurance, but some of our needs, especially among our PLHIV groups, to accessing some of like laboratorium tests for viral or CD4 is not currently under cover by our national health insurance. So there are some parts that still under the support from our donors. So for me, UHC is not only talking about how the government providing free services or providing treatment, but also should put more investment on the health promotion, because we talk about UHC, it's not only for treatment, but also promotion, preventive, and also to ensure that the quality of life, especially for our citizens of Indonesia. So currently, we just finalized our stigma index study 2.0. Thank you so much for GMP Plus, who also support us to finalize our study. We still identify that more than 19.5% of people living with HIV still have experience of stigma and discrimination at the health services. So, I mean, the HIV issue already started since, I don't know, 3-4 decades, but we still find that some of our communities still face stigma and discrimination at health services. So 9.5% at the HIV health services and around 14.5% non-HIV services. So it's still there. So for me, there are some recommendations. Yes, I can say the recommendation, especially regarding about several key barriers in accessing health services among people living with HIV and also population. First is about stigma and discrimination, of course.
Okay, Merinda, I'll come back to you because it will be very good that our participants are aware that there is a growth process. You know, before UHC came, people living with HIV/AIDS have a unique kind of stigma that they were experiencing. But now, one of the good things that I have heard is that the government of your country have been able to have a health insurance scheme system in place. So it means that a person with HIV and AIDS has some amount of covering that has been made available by government. But then, of course, it is very true that no government will be able to have it all. So we will get into those problems and then begin to see how then do we begin to scale up. But thank you very much, Merinda, for sharing that great insight with us. Let me see. Nelson, are you here? What has been the experience in Kenya? What has been your experience in Kenya, especially in the context of people living with HIV and AIDS? What gains do you think has happened? Where were we? Because definitely there have been some sort of improvement to a certain level. We want to see, has UHC changed the narrative at any level?
Thank you very much. And as I already said, my name is Nelson Otuoma. I'm based in Nairobi, Kenya, although I'm taking this meeting from Johannesburg. And coincidentally, I'm just in a meeting where people are discussing the high and rising cases of non-communicable diseases, hypertension, diabetes, kidney problem among persons living with HIV. And that is where the problem starts, because traditionally, our country is supported by Global Fund and the US PEPFAR, and they support strictly HIV, and that means for those who are HIV positive, they support ART. And in Kenya, they've been piloting universal health coverage, but unfortunately, they excluded HIV and TB, and saying that because they have funding, they just want to include conditions that don't have funding in the UHC. So in the last 3 years, there has been piloting of universal health coverage through primary health care, but HIV has been excluded, and the explanation is because people living with HIV are able to access free ARVs, but what they only access is ARVs, no any other thing. And the assumption is that if you have HIV, then the only thing that makes you sick is HIV, which is wrong, because you also suffer from certain conditions and you need universal health coverage. So at the moment, there is a discussion of a social health insurance fund, and the Ministry of Health and the government is promising, but it is just starting, that now they will include persons living with HIV in social health insurance. In fact, they have established to start in 2025 chronic illnesses and critical illnesses fund. But so far, communities and people living with HIV have always been left behind where universal health coverage is concerned. And I think the other challenge is also similar to what my sister talked about in terms of people who face HIV-related stigma and discrimination. May not go to facilities to demand for services. And that then means that people who have HIV are isolated, or their health facilities are separate from the general OPD where people get health services. So we hope that going forward, the government will put consideration into having persons living with HIV included in universal health coverage. But so far, we have been existing on the donor funding, which is also shrinking. Thank you.
Yeah, Nelson, thank you so very much. Clearly, from the voice of Nelson, you know that he's a very strong advocate. And sometimes as an advocate, you are tempted to just keep looking at where the issues lie, where, have not been addressed. But the clarity is to even know, is there any level of success that has happened over the year? At least, let me even say over the last 1 year, because I have heard you talk about an insurance scheme. Is it similar to what is happening in Indonesia? If yes, then before we now begin to go into the problems, because clearly you have laid the foundation of issues that are still hanging, that have not found national interest. But we want to even begin to see, have there been a change in narrative? Do we have some gains that we can point to? Then we now talk of improving. Nelson, I'll come.
I think from my observation, what I see is that there has been some progress. We are just beginning to start speaking around the need of persons living with HIV included in the universal health coverage. In the past, that was not possible because they would just tell you that the HIV clinic is separate and we are providing services free of charge. So you don't need to have a discussion here. But I've given an example of, actually it is a good example because treatment works. So people who have HIV live much longer, and then they have the onset of non-communicable diseases. So it is pointless to cover HIV and give ARVs for somebody who has hypertension, has diabetes, and has a kidney problem, because that will then kill them. And that the discussion is now starting in Kenya. Thank you.
Oh, great. Excellent. Thank you. Distinguished participant here, for those who are just coming on board, who are just joining us in this conversation today. This is the Universal Health Coverage Conversation. And today we have two individuals who are sharing their thoughts with us. We have heard from Erin, and just right about now, Nelson have also spoken. And each of them, we are looking at a round of questions to even examine, have there been some sort of progress given this area or the sphere where they work, where they spend a lot of time, and that is dealing with a neglected population, persons who are living with HIV and AIDS. So the first question was to even see if there is some sort of improvement. In Indonesia, we have heard very clearly an inclusion in there is a safety net of the universal health coverage, but specifically, they have enjoyed being part of a health insurance scheme. And clearly in Kenya, we have seen that people living with HIV/AIDS have now been included as part of the catchment area of the universal health coverage. Now, Merinda, let me come back very quickly with you. With what has been done so far, how can we scale up, achieving universal health coverage, especially among people living with HIV and AIDS? Does it look impossible for us to achieve, in your view, as an advocate? Do you think it is impossible for us to scale up achieving universal health coverage, especially among persons with HIV and AIDS?
Okay, my principle is nothing is impossible, right? Everything is possible. So with this high optimism to achieve UHC, I think we try to be inclusive, talking about people living with HIV, but also for all of the citizens of Indonesia as well. So I think there are several strategies that can help scale up efforts realistically. Is of course strengthening the health system. So we need to invest building robust health system that can deliver comprehensive services. So this is also including improving infrastructure, training healthcare workers, sensitize about stigma and discrimination, so GST, and ensuring the availability of essential medicine and technologies. And then if you talk about investment, of course, we need to increase funding and resource. We know that now for HIV program, I think more than 60% is come from the domestic funding and the rest is from the donors. And we really hope that our government will increase their domestic funding up to maybe 80%. So we cannot not always rely on to donors funding. But of course, our concern about the increasing investment, that government also need to put more robust allocations for the community program, community-based program like outreach worker, support system, peer support groups, community-led monitoring, and etc. And then the third things is about the policy and governance. This is the advocacy area. We need to create effective policy that promote equitable access to healthcare services. And then also strong governance can help ensure accountability, transparency, and participation from various stakeholders, including communities, people living with HIV, and also key population. And also, I think to scale up, to achieve our UHC is about the community engagement. If we talk about the community engagement, it's not only people living with HIV as an adult, but also the young key population, young people living with HIV or aging with HIV. And also this is, it should be involve communities from the planning, implementations of health services, understanding the needs and prevalence, and also integration of services. So our brother also already mentioned about the people living with HIV. We cannot only talking about ARV treatment. We also need to talk about the non-communicable diseases, kidney problems, diabetic, hypertension, and etc. And then I really believe that if we can put focus more on primary healthcare, we can strengthen primary healthcare as the foundation for UHC. So we need to ensure that the primary health services are accessible and affordable. And of course, it will significantly improve health outcomes. And I still believe that we need to strengthen our international collaborations like us today. We need to have a South-to-South learning. We need to hear also experience from other countries. So it can be like share the best practices, resources, and also if we need, we can also asking guidance and also technical assistance from our international collaboration partner. Over to you, Jonathan.
Thank you so very much. I was really drawn and taken captive into all that you have been saying. But very clearly, before I will make any comment, because I had to jot down a few things as you wrote, that is very, very, very essential. But let me reiterate just before I call Nelson to also share his thought on how we can scale up achieving universal health coverage, especially among people living with HIV and AIDS. Our dear participant, please feel free that we will also give room for you to ask questions when the time comes. So you could please note down your question, and when it is time, we'll recognize you and give you the opportunity to ask your question. Now, quickly, Nelson, I have heard very clearly from Merinda that it is super important to strengthen the health system of any country if universal health coverage must be achieved, because within the health system are a number of issues. You talk about essential medicine. You will talk about effective policies. You will talk about having the right manpower. What other means can we strengthen and see how we can scale up achieving universal health coverage, especially I'm zeroing down this time around on the population that you have been an advocate for. Over to you.
Thank you very much. And I also agree with my sister that governments will need to invest, including our governments that have been relying on donor funding. The donors are telling them to come up with a sustainability plan because now they are transitioning, which means they're reducing their funding. So what we need is domestic financing, money from the Kenyan government, for example, to take up universal health coverage. In addition to that, I think for persons living with HIV, you realize that for some time they've been given support, testing free and ARVs free of charge, not because anybody liked it. The donors didn't like people who have HIV, governments don't like people who have HIV, but because they demanded it. So it is also high time now communities partner with persons living with HIV or people living with HIV to join other communities to demand that they need access to quality healthcare through universal health coverage and through primary healthcare. If they demand as voters and they demand from their government that they vote for, then this is going to happen. Because if they keep quiet waiting for government to invest, it is not going to happen. The government will not train healthcare workers, the government will not strengthen and build health facilities, and the government will not have a robust procurement and supply chain. But communities must start the dialogue with their government and demand that when we are sick, regardless of our HIV status or any other thing, we go to a facility, and the healthcare that we are accessing must be affordable, if not free of charge. And for Kenya, that is also part of the Kenyan constitution. So people need to go back to the constitution and see which legal framework support the demand that they can tell the government, you put this in your constitution that you are going to provide access to quality healthcare to everybody, regardless of age, regardless of gender, regardless of sexual orientation, and regardless of HIV status. So the demand must come from communities and people living with HIV. And for that demand to work, the communities through their networks must also have the capacity to create that demand through advocacy. They must be empowered, which means they must have the knowledge of what they want the government to put in, and they also must have resources to make sure that they are communicating and advocating and making sure that they reach out to government officials. Thank you.
Thank you. Thank you so very much. And I am very enthused by your choice of words, of the fact that even enshrined within the constitution of your country, Kenya, it is an outcry or a clarion call of the fact that health needs to be available for every citizen of the country. And I will say by extension, I'm not sure that there is any country across the world that within its constitution does not have that clarity of the fact that the members of that country should have access to healthcare. Now, it is one thing to talk about having access to healthcare. It is another different narrative whether that accessibility does exist. Now, Merinda, how have you, within the network of people living with HIV and AIDS, how have you been able to manage the issue of stigmatization, while even though the laws are there, the point of service exists, but then these individuals still suffer stigmatization? And by the way, this stigmatization has the potential, depending on the individual who is suffering from HIV and AIDS, that stigmatization is capable of pushing the person into a mental health situation. So very clearly, again, how have you, within JIP, how have you been able to deal and manage with the issue of stigmatization? And Nelson, I would like you to keep pondering on that, as I will also come back to you on the same question. Yes, Merinda, over to you.
Okay, thank you, Jonathan. This is a very difficult question, actually, because after so many years, we still face about stigma and discriminations, HIV-related issues. For us, this is really disappointing, actually, because you know, information are everywhere, awareness are everywhere, and there's a lot of the social media or internet or any campaign or webinar talking about stigma and discrimination, but it's still there because, you know, when HIV came to Indonesia from the first time, the narrative of HIV is really bad. We only talk about HIV equals death. Now the situation is not like that, but that the old narrative is still there. And then if you talk about HIV, we talk about moral issues. We talk about risk behavior issues. We talk about our key population. We talk about our gay men. We talk about transgender. We talk about people who use drugs. We talk about the sex worker. This is the intersectional issue related to HIV, and also the issue of the key population. However, we put a lot of our efforts in two parts. First, to strengthening the community itself. So because from our Stigma Index 2.0 study, we identified that the internalized stigma among people living with HIV is 35.6%, which is quite high. So this is, we need the we need a very good strategy to improve their self-confidence, and also we promote about U equals U, because U equals U, I think, is one of the promising strategy to increase their self-confidence and also their self-esteem, especially because if they know that being HIV positive under treatment, being undetectable viral load, they are equals with untransmittable to others. It will create their future of life. They will improve their quality of life. So we need to, we still and need to campaign about U equals U. That's the first. And then the other part things is now working together with other communities, networks, and also other NGOs in Indonesia. We discuss about how we can put the target of the 10-10, because currently the approach of HIV program is very clinical based, part of the 95, 95, 95, 95. But now we push the government under the strategic and action, the national strategic and action plan to set the target for the 10-10s. So hopefully, if we have that 10-10s target, then the issue of the stigma discrimination is not only the responsibility of us and also other communities, but also part of the government responsibility. And also now working together with the UNAIDS Indonesia, now we are also with other NGOs and also other networks, we are working on the anti-discrimination bill. So because we are the national network, so we put our focus more on the advocacy. We push for to have the policy that also can support the community, especially to reduce stigma discrimination. So I think, yeah, that's that two things that now we are more focusing on from now and also until the ending of 2030. Over to you, Jonathan.
Wow, thank you so very much, Marinda. It's exciting to hear that there is a lot of work going on, but I also want to just add that the work on dealing with stigmatization will have to be a continuous process, because it is not just a one-off narrative. It's not a one-off action. Nelson, let me quickly come back to you. How have you been able to deal with stigmatization among the population that you work with?
Hey, thank you very much. I also need to start by agreeing with you that stigma still is persisting and high and very stubborn, and keeping people away from taking up care and living healthy lives. However, if we compare today and Kenya in the 90s, stigma has relatively gone down. It has not gone down completely, but if you compare with the 90s, the stigma that was there, HIV was like a death sentence and suicide and so many mental health cases, and people were really refusing even to take any prophylaxis or any prevention care, anything that would help them live longer. And this has come through a journey. I think our sister, during her opening remarks, shared a report that with the support of the global network of people living with HIV, they have undertaken persons living with HIV stigma index, which we call people living with HIV stigma index 2.0. Also in Kenya, we have undertaken that, and what that means is that you design questions. Actually, the GNP Plus and partners design questions to help us assess and measure, come up with like a quantitative and qualitative measure of perspectives and opinions and views of persons living with HIV on stigma, broadly defined, including self-stigma and external stigma discrimination. And through that, then you quantify and compile a report, and later on develop an advocacy plan and train communities. And because this is based on the greater involvement of people living with HIV for and by people living with HIV, it also has an empowering effect and gives the capacity and gives the knowledge. And then you end up with having HIV champions, people who are HIV positive, who can encourage their peers, who can fight stigma, who can go on media, including social media, and reach out and confront bad cases of stigma. So because we've done that a number of times with the support of GNP+, we have a critical mass of Kenyans living with HIV or openly living with HIV and reaching out to their peers and educating them and assuring them that despite HIV infection, you need to take up services. The other point has been what our sister has talked about. For those who are on treatment are undetectable, we say that undetectable equals untransmittable. And because you are not transmittable, then that builds your self-esteem, gives you a confidence, and you also get acceptability from other people who are HIV negative. And that is one way of confronting stigma. So we continue to emphasize that and educate people living with HIV to stay on treatment, make sure they are virtually suppressed and they are not transmitting the virus to loved ones, including children. But Kenya is also unique in the sense that Kenya is the only country in the world that has an HIV tribunal, that where you have cases of violation that touch on HIV and discrimination, whether somebody is denied schooling or employment, then you can actually go to the HIV tribunal for mitigation. I have myself been a member of that tribunal between 2018 and 2020, and it is really effective. The only challenge is that people fear going to the tribunal because probably the media may catch the case, and then you also end up like being exposed. But we have explained that it needs to be a safe space, and these days they operate outside the court sessions and the media is not allowed. So anybody who wants to share their story can share, but those who don't want are heard on camera. So those are areas that we continue to work on, but I agree that stigma will take time, particularly among the people we call people living with, key populations living with HIV, sex workers, men who have sex with men, people who inject drugs, and also adolescents and young people are still facing challenges, but we are still continuing to provide that education and advocacy and to make sure that we have policies and laws that protect and support persons living with HIV. Thank you.
Wow. Wow. Thank you. Thank you so very much. Distinguished participants who are here, one big lesson I have heard today, two things. Actually, one from Merinda. She talked about the beauty of collaboration. JIP in Indonesia, together with UNAIDS, are working on a collaboration to put up a bill that will be focused on people who are living with HIV and AIDS to better their ability to access care. Today, the only country in the world that has a tribunal for HIV and AIDS is Kenya. And I think it resonates well with some of the points that Merinda has made, that it is important also that we learn from each other, which is also going to be part of the strategy to strengthen and scale up the ability to be able to achieve UHC across neglected populations. Okay, and I think this is a very noble path that I have heard today, having a HIV tribunal. And maybe, Nelson, it could also be another added, beyond talking about media is not allowed, you can come up with a policy statement, that the media people will be involved in drafting such a policy so that it doesn't matter, even when a person comes, any media person that acts otherwise, the policy is there, the person is held responsible. So today, we have seen that the action of stigmatization has no end. Even with the fact that there is a tribunal, people are still reluctant to come forward because of being stigmatized. So whether you are joining this webinar today from Nigeria, from Kenya, from Nairobi, Kenya, or you are in Johannesburg, or you are in Indonesia, the clarity is that people who are within your community, who are HIV and AIDS positive, they suffer stigmatization. And it is your responsibility and my responsibility to alleviate this pain of stigmatization so that they can also have a decent life. Having HIV and AIDS is not a death sentence. Rather, there is still opportunity for one to be able to contribute meaningfully to the society where she or he actually do belong to. Now, Nelson, I will come back to you. Listen, there's an outcry of accessibility of care, especially whether looking at it from a curative point, that is getting to the hospitals. Today, globally, there is no country that is not going through the same narrative of a shift of skilled manpower. There's migration of a lot of skilled manpower. How then do we still cry out for equity when even the system itself is suffering from skilled manpower migration? How do we balance this conundrum, Nelson?
Thank you very much. And Kenya is a country where we train a good number of healthcare workers, whether they are nurses, clinical officers, and doctors. And because of the way the government treats them and low remuneration and low pay and lack of support through housing, most of them migrate to the West. I think most of our nurses are in the UK and a number of African countries, including Johannesburg. But I think that is where it starts. And our sister already talked about the government need to invest to strengthen health systems. There is no point of promising people universal health coverage when the person dispensing care is not available and is not satisfied and is also not well taken care of. So the people that the government will still need to invest in training healthcare providers. And after training healthcare providers, they must be given employment and be paid good salaries to retain them in the country. That is when you get a good quality service that is defined by universal health coverage. And the best way is like what I said, governments need to invest in health, because there's no any other way of having it. And countries are now looking at inside their countries. We have the example of recent elections in America, and the elections that are there, we still don't know what will happen, but Americans will be looking into America. So we should not expect that Americans then will come to invest in our countries like Kenya or in Uganda or even Tanzania. So it is high time the citizens of Kenya started discussion with their leadership and demanding, as I said, that we elected you into an office, we have a constitution, and you have promised, please put money into health and employ healthcare workers and pay them well, and provide for them, also provide work safety policies, and also give them medical cover so that even them, when they become sick, they can also be seen and we can also be supported. There is no any other way around it. It is just a matter of increasing money so that healthcare workers are supported. The other approach, apart from direct government allocation, there is partnership with other actors. I know there are countries where USAID and other partners come, whether private sector or faith-based sector, it can come in and also help with the additional healthcare workers, including nurses. So that partnership should be fostered, and governments must have a conducive environment for allowing private sector to invest in a country and to build hospitals and to give subsidies and support also tax reduction, so that country is not seen as a very high level of taxation that keep private sector away. Thank you.
Well, I have heard very clearly the need to improve domestic funding. But somehow, when you even engage government will also tell you that she is also looking for money on how to invest in the system. But thank you so very much, Nelson. Let's see. Mirinda, you are here. What is the experience like in your country? How do we balance this conundrum? You have a global outcry. You can even call it a national outcry of the need to have health accessible and available to everyone. But at the same time, you also have a huge migration of skilled manpower out of countries. How do we balance this narrative? Mirinda, are you there?
Can
yes,
you repeat your
I can hear you.
I lost you. Can you repeat the last question, please?
The question is, listen, there is an outcry by all of us as professionals, and it's a global outcry of the need to have a strong and a viable health coverage that everyone will be able to have access to. Now, globally, you also have a pandemic, if you want to call it that way, that there is a huge migration also of manpower, skilled manpower. So we want people to have access to care, but the care providers, again, are moving elsewhere. So how do we balance this outcry among population?
Well, I think Nelson already mentioned a lot about the balancing about the migration skill manpower. So I think especially we need to strengthening the local workforce, of course. This is also including, I think Nelson already mentioned a lot about training education program from the local healthcare workers, retention strategy, health workforce planning, conduct through assessment of healthcare workforce needs to ensure that the supply of skilled workers aligns with the demand. And also, I think we need to have a strong collaboration with educational institution. So partner with universities of training institutions to align curricula with the needs of the healthcare system. This can ensure the graduates are well prepared to serve in their communities. And talking about for the balancing, I think the government also need to ensure that they provide incentives for rural and underserved areas, over incentive for healthcare professionals to work in rural or underserved areas. This could include loan forgiveness program, housing assistance, or relocation bonuses. And one thing that I think nowadays about utilizing technology, leverage telemedicine, digital health solutions to expand access to healthcare services, especially in remote or underserved areas. And last but not least, about community health initiatives. So empower communities to participate in their healthcare planning and delivery, because community health workers also play a very crucial role in bridging gaps and also providing essential services. Yeah, thank you, Jonathan.
Thank you. And I think I love that point that you have made, the need for collaboration and collaboration, meeting, interfacing with the academia, also see how curriculum can be improved. And then, of course, as Nelson have also mentioned, the need to strengthen domestic funding. These are options that we can have to be able to use to balance this narrative or to balance this reality that we are going to, or that we are being confronted with every time. Now, Merinda, earlier on, you talked about when I asked how we can scale up, dealing with, with people living with HIV and AIDS. You made mention of community engagement. And so my question to you, how have you, over the years, effectively, how have you engaged communities, especially beyond individuals living with HIV and AIDS? How have you embraced, pull communities together to be able to see, the beauty that, that the universal health coverage has in stock for them?
So we started our program of community-led monitoring. So under the community-led monitoring, we have 3 pillars, actually. So the first is to ensure that the community-led monitoring mechanism is in place, especially in the primary healthcare or the health services that are provided by the government. To have existing CLM or community-led monitoring in the health care providers, what we need to do to invest in community empowerment. So we put a lot of investment to ensure that our end beneficiary as an advocates to fulfill their needs at the health facilities, to improve the quality of services, because I think if we invest more our end beneficiary, which is people living with HIV at the health facilities, being as an advocate, it's not only to strengthen the health system, but it's also will strengthen the community health system. So a community system strengthening. So for us, if we put more investment on the community, providing them training, capacity building, advocacy training, sensitizations about human rights, sensitizing about how to reduce stigma and discrimination, we see that is the big opportunity for us to ensure that UHC also can be enjoyed by our community people living with HIV. So now we have our third year in our implementation of the CLM. We work more than hundreds of health facility. We put the community as an beneficiary at the health facilities becomes our community champion. So they're not only talking about themselves, but they also empower others. They're providing support to their peers, and also because they also identify about the quality of health services in their own health services. We really hope that they can also advocate for their needs at the certain level. For example, if there are some issues that cannot be solved at the health facilities, we really encourage them to increase the advocacy level to the district health office, to the provincial health office, and also up to the Ministry of Health at the national level. So for us, the greater involvement and people living with HIV, it's still needed. And we really believe that if the end beneficiary is not only as end beneficiaries, but also as a subject of the advocacy, I believe that UHC can be enjoyed to our people living with HIV in Indonesia. Thank you, Jonathan.
Thank you so very much, Mirinda. That was very thought-provoking. And I'm going to come back to you about something that you have stated earlier, and especially it has to do with the initiative that you are pulling through in your country, especially as it borders around stigmatization. And I will come back to you on that, Mirinda. So let me go to Nelson very quickly. Nelson, in your view, as a person who has engaged over a period of time, what do you think is the responsibility of communities in achieving health, universal health care?
Thank you very much. Communities, first of all, start with individuals. You know, universal health coverage is not just waiting to be sick so that you go to the hospital. First of all, there's the prevention aspect. So communities and persons, particularly persons living with HIV, need to have the treatment and health literacy to understand what diseases to prevent and how, and then educate take the first step amongst themselves, and then through their groups like networks, take that consideration. So prevention, that is a key component of universal health coverage, falls on every individual, and also for those who are leaders within communities to also educate others to follow suit. Secondly, communities also need to demand and take up and utilize services that are available. I also know that sometimes there are services in health facilities, including for those who are HIV negative, self-testing kits. Sometimes they are in Kenya and they expire. The communities also need to take up other services outside. Even if they're living with HIV, outside HIV, like TB, there are many people who become sick and die from TB because they have HIV, but it is important for them to take and utilize services for TB treatment, care, and support. But more importantly, the most important thing is to hold governments accountable. I go back to looking at the relevant constitution in this country, Kenya. Article 43 of the Kenya Constitution promises the best attainable standards of healthcare. So they need to educate themselves among that, and then use that to reach out to government officials and politicians and tell them that because this is part of the constitution, we demand that you increase resources so that we realize this promise of the constitution, and make sure that when resources are allocated, communities must also monitor. And in Kenya, we do community-led monitoring so that there is no or reduce cases of corruption and theft of medicines or theft of items that are in facilities, and also support healthcare workers, including nurses, doctors and clinicians so that they do good work and support them when they ask government for increased pay or for better working conditions. Thank you.
Thank you. Thank you so very much, Nelson. Our distinguished participants, we are very keen and looking at our time. We don't intend to keep you longer as we have planned. So we are gradually rounding up our discussion for today. I may just say in a nutshell, I have about 2 questions more to ask, and then take a pause and see if there are questions for me to pick from the chat option. So please, right about now, if you are there, it doesn't matter whether in French or in Spanish, if you have a question, drop it on the chat option. Our interpreters are here to help us with the interpretation. Again, Nelson, I will put you on the spot a little more. Do you think, or will you agree with me? This time around, it's not even think. Will you agree with me that the absence of policymakers in conversations that have to do with universal health coverage could be a missing link in why UHC has not been achieved? You know, if you will compare it with how much globally people have made an outcry of the need for us to achieve that. And then, of course, if you will agree with me, then the question would then be, how then do we get them actively involved in this vanguard? Over to you.
Yeah, I think mostly in Africa, and in this case, I'm drawing my example from Kenya. We have a political leadership, both parliamentarians or ministers, or maybe even the president. When they become sick, or when their family member becomes sick, they run to either India or Europe. And I think the closest they run to is in Johannesburg in South Africa. I think sometimes they are out of touch with the reality of the healthcare system in their countries because they don't seek care in those facilities, and they may be missing as decision makers and other policy makers in terms of making sure that they put systems and resources in place to help their citizens. So I would still just go back to the citizens ganging up together and making sure that during elections they elect leaders who are proactive and they can come up and interrogate party manifestos before they do elections. But even after elections, a constant reminder that people who are your countrymen and countrywomen need to access health services within the county boundaries because they cannot afford to travel, they cannot afford air tickets to go to India or to go and seek medical care in Europe. As I said before, today in our country, they provide ARVs free of charge for people living with HIV, not because they like it, but because people living with HIV demanded it and continue to be very vigilant around any discussion of cost sharing or putting any cost into it. And therefore, if citizens gang up and say that our key concern during the next 1 or 2 years is to make sure that we have affordable health care that will not put financial burden on us when we become sick, I think the country will respond and people will have good health care. Thank you.
Wow. I chuckled a little as you spoke that we should elect people who are proactive. And somewhat in my mind, I wonder if there is a matrix to identify that. That is why I chuckled. But thank you so very much, Nelson, for throwing that question to me, or for throwing that clarity. Merinda, are you there? Let me also throw the same question. Maybe there could be another perspective to this reality. Do you agree that the absence of policymakers, whether we may call them politicians or leadership, their absence in the discussion of achieving universal health coverage, could it be the missing link? If that is the missing link, then how then, whether it is the missing link or not, how then do we get them involved in conversation health coverage? Merinda, if you're there.
Yeah, I'm still here. So, Jonathan, the situation in Indonesia is different right now because we have our new government. We have a new president. We have our new ministries. We have our new parliamentaries. So, you know what? Like every 5 years, we need to start all over again from zero. Actually, to ensure that policymakers, well, not only talking about UHC, but also talking about HIV, because what I really sad about during these last 5 years, there is no one in our high level politicians or government official or policymakers want to speak about HIV. It's really disappointing, and I know that this is our challenge that we need to overcome. We need to answer about this challenge. So I think we need to currently, because we have our new president, we have our new ministries, we need to mapping our key actors right now. We have to identify who are the policymakers that maybe can be our allies for these advocacy things. So maybe after we identify the key actors who can be our allies for this process, then we can set up our advocacy roadmap. Because HIV is not our government prioritized program or prioritized plan of the national plan. So we need to start to sensitize about these issues, and then we need to talk. We need to ensure that we not only approach our Ministry of Health, but also other ministry that related to health, especially like Ministry of Welfare, Ministry of Law and Human Rights, or Ministry of religious and ministries of I don't know, like women, etc. So we need to identify our key actors. We need to identify our parliamentaries that also have concern about HIV and UHC. So, and because of that, us as a communities, we cannot work alone. We need to have a strong collaboration with other partners, especially with the communities partners. Thank you.
Okay. Yes, it is important that if that must happen, every active entity, every active government arm must be brought to the table for conversations. And then maybe I will quickly just say this. There is a question that was picked from the chat, and that will form about my wrap-up question. And this is very specific to Merinda. You shared about Indonesia working on a stigma and discrimination bill. Will this discrimination, or will this decriminalize key population? Or what is the direction that the bill has in stock, or the policy? I think the person just needs some insight into that policy.
Yeah, so the bill is not only for the people living with HIV, and also it's also talk about key population and other marginalized groups. So now we are working with our other networks and UNAIDS Indonesia, and the difficulties is because next year we will have our new penal code that already criminalize some of our key populations. So we really need to work very carefully, because I believe you understand that bill cannot be contrasted with other bills, right? Especially the penal code, one of the highest regulations of this country. So, but the one thing that we need to ensure in our bill is, if there's some discrimination act happen, there will be sanction for the person who become the perpetrators. Because Indonesia is not only have our civil law, because our types of law is civil law, because we also have our sorry, my daughters call me. We also have our how do you call it, like cultural law and also religious law. So we really need to ensure that all the bills, it should be aligned and integrate one of another. So this is a very crucial step, but at least in the bill, there will be articles, those who become perpetrators, there should be sanction for them that can be put maybe in jail or get bailed or get a fine or something. That's still on the now we are working on that progress. We're also working with the parliamentaries, but sadly, because now we have our parliamentaries, the new parliamentaries, so like we need to start all over again. So, but yeah, this is the advocacy, the art of advocacy, right? So
yeah,
we're still working on it, Jonathan.
Excellent, thank you. This will be the very last question to our dear participant. Please bear with us because sometimes you get so excited talking about something that is very passionate to you. And I will start with Merinda. How do we get the next generation excited about issues that we are talking about today? Because today, if you look through, you find out that they are all more professional, but the next population, the next generation may not be aware. So how do we get the next generation to be part of this outcry? And then the same question that will go to Nelson as soon as Merinda is done.
So, Jonathan, I think what we need to start with is talk to them, talk with them, provide more investment for our new young populations, because we need to sensitize them, because the health is a very important issues, and they need to understand why we need to talk about UHC. That's the first. Put more investment, and then put them in the tables, talk with them, discuss with them, because our perspective maybe will be different with their young perspective. It's totally different horizon. It's a different world. Because now there's a lot of investment now go through our young populations, our young people living with HIV, and also young population. That's a very good start. And then give them support, and then strengthen their organization. If they already have organizations, strengthen them capacity management, leadership capacity. We need to put more capacity building to our young generation, and then we need to follow about the way they think. The way they think is really different with our old generation, our major generation. It's really different because they love technologies. They have a new perspective of life. We need to understand about that as well. So yes, engage with them, put them in the table, discuss more, put more investment, and give them space, safe space. And then give them space to talk, give them space to share about their ideas, because from that we can learn, and then we can also collaborate more strongly with our young generation. Over.
Thank you so very much. Nelson, let me get your thoughts on the same question.
Thank you. I think the lesson is for all of us. The world is becoming more fragile with pandemics, with climate change. So it means diseases are increasing, and then it means also human beings are also becoming very vulnerable. It starts with the parents. Parents need to sensitize their children and their young people that there are diseases that they used to see in very old people when people were 90 or going to 100. But those diseases are now coming when you are 20 or 40 or even 60. Non-communicable diseases. Then we have pandemics like COVID, mpox, and so on and so forth. So young people need to be sensitized and educated to realize that they have a responsibility to keep healthy, but also to educate their colleagues to also keep healthy and make sure that they follow what clinicians or doctors tell them. More importantly, let us go to schools, in learning institutions, and make these things part of the subject. So it is not just general science, but we teach human health in schools so that people get used before they grow up, before they become adults. Lastly, and more importantly, let's make it more interesting for young people. Like Linda said, they use TikTok. Let's have TikTok discussions around health. They use Instagram. They do social media. Let's make it more interesting, and then let us also put incentives. In a long time ago, when I was young, there were scouts that were being given awards. So where are the young clinicians? Where are the young doctors? Why can't we award them if they pay attention to health? And then we have champions from young age that can also be motivated. So when they become adults, they just continue in that work. Thank you.
very annoyed that you will get to realize that what you talked about 20 years ago, they are still talking about it 20 years later. And the only way to avoid that is if we learn to engage the next generation in our respective conversations. I want to thank everyone who has created time to be here today, this afternoon, evening, as the case may be, depending on where you are. I want to thank Nelson for being here. I want to thank Merinda for being here. Permit me with no order of priority, Abdul Malik, thank you for being here. Amit, Chipo, Claire, Edbley, Edward, Edgar, Ibrahim, Idara, Joanne, Miriam, Pamela, Randy, Richard, Shulai, Wangi, and then Techno BG6. I don't know who is that, but I'm sure that's your device name. If you are the one with Techno, thank you for being part of this conversation today. And I also want to thank our interpreters. Thank you so very much. I will request, if you don't mind, the host, I will request that we all turn on our video, then we can just have a screenshot, a photograph of everyone who has been here as our own way of saying thank you for being here today. Then the conversation would have a nice day. So please, all that I have called their names, if you can hear, please turn on your video wherever you are so that the host will take a screenshot of everyone. Thank you very much, Edgar from Malaysia. We're grateful that you joined us. Once the host is ready to take the screenshot, we will be glad. And then thereafter, we can be able to say the day has been well spent. Done?
Yes.
All right. Thank
you so much.
Thank you very much, everyone, for being here. Merinda, we're very grateful. Nelson, thank you very much, and do have a beautiful day wherever you are.
You too. Bye-bye.
Thank you. Bye-bye.